Good morning, all. Today's topic is medical emergency. Today, I am going to present cardiovascular and respiratory emergency. So, emergency is a serious and unexpected situation that required immediate action. And the common emergencies include fainting, diabetic coma, anaphylactic shock, epileptic seizure, cardiovascular collapse, thyroid crisis, adrenal crisis, asthmatic attack, and shock. Clinical presentation includes sudden loss of consciousness, chest pain, and convulsion. And the prevention include take proper case history, stress reduction protocol should be followed, painless treatment, proper instruction, and preparation of emergency. So, cardiovascular emergency. Common emergency is angina. Angina is paroxysmal discomfort, often described as heaviness, pressure, tightness, choking, or squeezing. In retrosternal and may radiate to shoulder, arms, and may radiate to neck and jaws. And the management includes semi-sitting position, provide oxygen, and glyceryl trinitrate 0.5 milligrams sublingually, and repeated dose can be given after every 5 minutes interval. And pain, if persists after 3 doses of nitroglycerin, then it will be myocardial infarction. So, along with nitroglycerin, you can give 300 milligram of aspirin, or IV cannula can be placed and give 5 to 10 milligram of morphine sulfate intravenously. The nitrous oxide and oxygen combination can be given. If it is hypertension, that is elevation of diastolic blood pressure more than 120 millimeter of Hg, then headache, dizziness, nausea, vomiting, visual impairment, and neurological changes can cause. And the procedure should be done only if diastolic is less than 90 millimeter of mercury. And the management, place the patient in semi-sitting position, then give oxygen, diazepam, check vitals, and give 10 milligram of nifedipine sublingually. It is hypotension, then that is reduction of BP, then patient may show restlessness, confusion, nausea, stupor, and coma. The management include place the patient in central and bug position, then clear airway, oxygen can be given, vital should be checked, and IV fluid can be given. If systolic is more than 80, then monitor and supportive therapy should be given. If it is less than 80, then vasopressor can be given. If the pulse is less than 60, then atropine 0.4, 0.6 milligram IV can be given. Then phenylephrine can be given 2 to 5 milligrams subcutaneously or intramuscularly, or 0.2 milligram intravenously. If it is cardiac arrest, then assess the situation and shake the patient and ask the patient, are you okay? Then call for help. Then start basic life support or CPR. Then respiratory system. Common complication is asthmatic attack or status asthmaticus. It is the increased irritability of tracheobronchial tree to various stimulus, including allergens, infection, non-specific irritants. Then wheezing, chest tightness, and chest congestion are the symptoms. Management, place the patient in sitting position, then give oxygen, and patients on medication can be given. If it does not recover, then epinephrine 0.3 to 0.5 milligram subcutaneously can be repeated 15 minutes after that. Then salbutamol nebulizer can be given. Then amlodipine can be given. Then hydrocortisone sodium succinate 200 milligram or prednisolone 30 milligram can be given. If no response in 2 to 3 minutes, then salbutamol or terbutaline IV or 1 ml of 1 in 1000 epinephrine can be given. Then call for ambulance. And for hypoventilation, that is increase in alveolar ventilation caused by abnormal and rapid breathing. Predisposing factors include anxiety, lesion of CNS, metabolic acidosis, fear, and stress. Clinical features include dizziness, difficulty in breathing, palpitation, mild pain in chest, epigastric discomfort, numbness and tingling of paresthesia of fingers and toes, headache, faintness, mental confusion, and loss of consciousness. And the management places the patient in comfortable position, then airway, calming and reassure the patient, encourage the patient to rebreathe slowly into the paper bag or ambu bag at a rate of 10 times per minute to recover acidosis. And if it is respiratory obstruction, that is obstruction in the neck due to swelling in the neck, to trauma or tumor, or unconsciousness due to tongue fallback or blocked pharynx due to foreign body or inhalation of food. Foreign body or airway obstruction during dental procedure, the potential is great that the object may fall back into the posterior portion of the oral cavity and pharynx, and the introduction of sitting position increase this incident. When swallowed, usually pass completely through the GIT and in some cases cause GI blockage, peritoneal abscess, and perforation. When aspirated, entire larynx and may rest in a part of bronchi. Complication include infection, lung abscess, pneumonia. And the instrument used to prevent aspiration include rubber dam, oral packing, suction, dental assistant, chair position, manual forceps, and ligature. Clinical features include cough, gag, choke, wheeze, and laryngeal or bronchial irritation. Management: place the patient in supine position or Trendelenburg position. Use manual intubation forceps or suction. And on placing Trendelenburg position, this object may fall into a patient, come closer to the patient oral cavity, and it is easier to remove using manual forceps. Or instruct the patient to bend over the arm of the chair and head down and encourage to cough. And if the object is not visible or swallowed, consult the radiologist, obtain appropriate radiograph. If the foreign object is located within the GI or respiratory tract, consult appropriate specialist. And management of aspirated object: place the patient in left lateral decubitus position and encourage the patient to cough. The object can be retrieved and initiate medical consultation. If the object is not retrieved, consult with radiologist or emergency department and obtain a radiograph and perform bronchoscopy. And establishing airway can go for non-invasive or invasive procedure. Non-invasive procedure include back blows, manual thrust, abdominal thrust, chest thrust, and finger thrust. Invasive procedure include tracheostomy and cricothyrotomy. In infants, place the infant's stomach down across your forearm and give 5 quick forceful blows on the infant's back and heel of your hand. The Heimlich maneuver, that is, cover your fist with your other hand and thrust up and in sufficient force to lift the victim off his feet. This produces a rapid increase in intrathoracic pressure, acting as an artificial cough that helps to dislodge a foreign object. In unconscious patient, you can go for abdominal thrust, chest thrust, or finger thrust. Abdominal thrust means kneel down on patient's side and place the heel of one hand over the abdomen between the waist and the rib cage and place the other hand on the top of the first and thrust inward and backward with quick thrust. And the surgical intervention include cricoid puncture and tracheostomy. Thank you.